Hi, I wanted to share with you an interesting case that you might not be able to see very often, at least here in the United States. This is a gentleman who came complaining of nasal airway obstruction. And on the CT scan, he had a nasopharyngeal mass all the way on the left side by the adenoid. But what he's really complaining about was this right-sided nasal airway obstruction with this mass that's at the head of his right inferior turbinate blocking his nasal airway. He had this resected previously once before and was told it might come back. And here's what it looked like endoscopically. This is in the operating room. And what we have here is the left-sided nasopharyngeal mass, very rugated looking, almost papillomatous looking in an appearance. But let me give you a sense of orientation. Septum is there on the left, eustachian tube orifice there, nasopharyngeal mass as shown there. And this mass tended to bleed a lot with just a little bit of provocation. Here's a microreader that we use to remove the nasopharyngeal mass, and then we cauterize the base. And interestingly, here on histologic evaluation, this is what it looked like. We have this kind of papillomatous looking lesion. Also, we have large round globules, almost like little spores with small little dots inside there. Very characteristic of this lesion, but something that's actually not seen all that commonly here in the United States. And here's a close-up of the vacuole, or that little rounded lesion inside the papillomatous sample. And you can see it's very characteristically clear on the inside with basophilic elements internally and also surrounding inflammatory cells. What is this? This is rhinospiriosis, caused by an organism Rhinospiridium seabury, which is thought to be either a fungus or a protozoan. It's been multiply characterized or classified over the years. It's acquired by swimming in contaminated water. So this gentleman was from Southeast Asia and had it resected once before, as I had mentioned, a long time ago. Treatment for this is aggressive resection locally with cauterization of the base to help reduce the potential for recurrence. If there are systemic issues, dapsone has been used in the past as well. So this case is kind of one of those clinical zebras, something that's not all that frequently seen here in the United States. You might clue into this potential diagnosis depending upon patient history, maybe a little bit of social background. Certainly the histologic slide that you saw is very characteristic of Rhinospiridium. And so hopefully you learned a little bit more and could tune up your spidey sense if you happen to see something like this in the future. If you have any insight further or your experience, I'd love to hear your experience potentially with Rhinospiridium as well. Drop me a line. Thanks.